Good evening, students. Good evening to all of you, and welcome to most important PYQs of INI-CET session. We are just going to wait for 1 minute more to let everybody join in, and then we will start. Good evening to all of you. Okay, I guess everybody has joined. Chalo. So, I have curated 10 most important questions. Okay. Those questions you have to be very thorough with those questions because they have been asked in NEET as well as in INI-CET. Okay. So, these are most important 10 questions that we are going to be discussing today. Okay. Let us start with the first question. Now, I would first tell you a very important point regarding this that the landmark based questions that you get, okay, that you get in your exams, like landmarks in IUPAs, landmarks in OPGs, or you get this CBCT views or slices to identify, right? So, these questions carry most or of the scoring potential, okay? So, if you know these landmark based question, you can easily fetch good marks, okay, with these questions. So here first question is this teardrop shaped radiolucency seen bilaterally on OPG is most commonly. So they are just asking you the landmark that we have, that is this teardrop shaped radiolucency, correct? Teardrop shaped radiolucency that we have bilaterally. Here also if you see, there is a inverted teardrop shape, not just teardrop, inverted teardrop shape. Okay, so I'll just show you in the skull how do you see this fissure, okay, or the space. So here you see these two bones. This is one bone, this is other bone, correct? The space between the two bone is seen in the OPG like this, inverted teardrop shape. Which are these two bones? First bone is a maxillary bone. Second bone is a pterygoid bone. Correct? So the space or fissure is called as pterygomaxillary fissure. Okay, so inverted teardrop shaped radiolucency that you see bilaterally on OPG is nothing but pterygomaxillary fissure. So this is the axial slice or axial section, correct? Axial section of CBCT. And here also this yellow arrow is giving you this fissure, pterygomaxillary fissure, okay, pointing out this pterygomaxillary fissure, correct? So this is a pterygoid bone. This you see here, this is pterygoid bone and this is a part of maxillary bone, correct? So this is the easy one. Next two important landmark that I would like to tell you guys is this two radio opaque lines. Okay, anybody knows this can post it in the chat box. This two radio opaque line, this is the first radio opaque line, and this is the second radio opaque line. Just beside the teardrop shape, that is pterygomaxillary fissure, you have these two radio opaque lines bilaterally. Here also, this is first and this is second radio opaque line. So they can ask you this landmarks also, and these two radio opaque lines are most confusing one. Okay, so I'll just tell you the number two landmark is nothing but posterior wall of maxillary sinus. Posterior wall of maxillary sinus. Just beside the pterygomaxillary fissure, the radiopaque line which is there is posterior wall of maxillary sinus. Okay. And number one, the structure which I have marked as number one is nothing but zygomatic process of maxilla. Zygomatic process of maxilla. So please remember these two landmarks. You can get confused in these two landmarks. Okay, the two radiopaque line besides the pterygomaxillary fissure. All right, please remember this. You can take a screenshot or just after the session, you can just pause and take screenshot of this. Okay, number one is zygomatic process of maxilla. Number two line is posterior wall of maxillary sinus. Okay, please remember this. Chalo, moving on to the next question. This is easy, direct pick from textbook, but when you see, hmm, I'll just change the color of it. Okay. Now, this is the direct pick from the textbook, correct? But this question can be given or modified in clinical based question. Clinical based question. So we have to prepare according to that. Correct? The answer for this question is easy. Option A, osteomyelitis. Correct? Moth-eaten appearances seen in osteomyelitis among given options. Okay. But how this moth-eaten appearance will appear radiographically? When you see this moth-eaten appearance radiographically, correct? They can give you they can just twist this question, give you clinical based questions such as this patient came to your department and complains of pain and swelling first discharge. Okay, and with other systemic symptoms such as fever, malaise, lymphadenopathy, and the radiograph tells you this. Okay, and then you have to diagnose the condition. So then that becomes difficult. Okay, when they give you clinical based question, that becomes difficult. The answer is easy, correct, but you have to run your mind, and then you have to mark the correct diagnosis. Okay, so you have to know each and every aspect of the condition. You have to know the radiographic appearance, then systemic features, then clinical features. Okay, so, osteomyelitis, we all know it is inflammatory condition, correct? It is inflammatory condition. And this inflammatory condition affects bone. So, bone, yani cancellous as well as cortical bone. The periosteum is also affected, correct, in osteomyelitis. So, here the causes for this inflammation are odontogenic, that is carious teeth, sometimes the trauma, the extraction wounds, or the radiotherapy. These are some causes for osteomyelitis, correct? Some conditions that can cause this osteomyelitis, such as osteopetrosis. What is osteopetrosis? It is marble bone disease. The bone becomes brittle, correct? And one more condition is florid cemento-osseous dysplasia. These all conditions can cause hypovascularity. These all conditions cause hypovascularity, and due to hypovascularity, there is high chance that this bone gets inflamed. Okay, and that can cause osteomyelitis. Okay, so just know the causes, the condition which can cause this osteomyelitis, and the radiographic feature, as you can see over here. The first radiographic feature or the earliest sign of osteomyelitis, this is also osteomyelitis, moth eaten appearance. The earliest sign of osteomyelitis is nothing but decrease in bone density. Decrease in bone density. Correct? Now, this decrease in bone density will make the trabeculae appear fuzzy. Trabeculae appear fuzzy. Okay. Now, what happens is, as the infection spreads, what happens is the trabeculae loses the continuity. Trabeculae loses the continuity, and there the bone resorption which occurs due to it, due to inflammation, will be seen in more pronounced way. Now, in advanced stages, this is the beginning of the infection, okay, beginning of the inflammatory process. These things happen. Then advanced stages mein, what you can see is this condition, moth eaten appearance. How it will appear? There will be multiple foci. Okay, so there will be multiple foci. Can you see? There will be multiple foci of rare fraction. What is rare fraction? It is decrease in density. Okay. So rare fraction, multiple foci of rare fraction and sclerosis. So decrease in density as well as increase in density in some areas. And that will lead to fragmentation. Fragmentation of bone, and the fragmentation occurs due to sequestration. Sequestration is what? Dead bone. Okay, dead bone. So this multiple foci of rare fraction is decrease in density, and sclerosis is increase in density. Okay, and this appearance is irregular and ill defined. Okay, and this is called as moth eaten appearance. This is called as moth eaten appearance. Okay, so, I hope this is clear. The radiographic appearance you see in osteomyelitis, the causes, the how it actually looks. Okay, I hope everything is clear. And the uh, you can say, if at all they twist this question into clinical based question also, then you need to answer that question also. When you know the basics of it, you will be able to answer clinical based question also. Okay. So in osteomyelitis, what symptoms do you see? You see pain, you see swelling, you see pus discharge, symptoms and signs. Okay. And systemic features may you see fever, malaise, and lymphadenopathy, etc. Okay. So I hope this question is clear. Okay, my audio is not clear, I guess. I'll just check with the tech team. I'll just check with the tech team. Just wait for 2 minutes. Some students are not able to hear my voice, so they can just uh, re-log in or go back and again join the session. Okay, okay, now it's clear, I guess. Okay, okay, I'll explain it again. Okay, no problem. Hmm. Those who are not able to hear it clearly, please rejoin the session. Yes, okay. All right, chalo. Moving on to the next question. So, moth hidden appearance, osteomyelitis. I hope the concept is clear. And moving on to the third question. Okay. So, parallax is seen due to. So, there is the word parallax. Okay. Parallax is seen due to. Uh, Unsharpness used in extraoral radiography, single emulsion film, double emulsion film. First of all, I'll directly tell you the answer and then I'll explain what is parallax. It's double emulsion film. Okay. So, uh, we have studied in principles of projection geometry, principles of projection geometry that the distance between the object and the film should be as small as possible, correct? To get sharper image. To get sharper image. Okay. Now, when we use double emulsion film, there will be emulsion layer on both the sides of film. Correct? So this is a X-ray source. This is our object. This is our object. This is double emulsion film. This is the first layer. This is the second layer of emulsion. So latent image will be formed on both the layer. Okay. Now, when you look at the distance between the first layer and the object, okay, and you compare this distance with the second layer and the object, of course, the second layer is more farther, correct? Second layer is more farther than the first layer, correct? And what our principle tells us? The distance should be as small as possible. So, first layer pe jo bhi image will be formed will be more clearer as compared to the image which will be formed on second layer. So second layer पे जो भी image बनेगा that will have little unsharpness as compared to first layer. Okay, so that is called as parallax. That is called as parallax. Okay, and the question is direct. Parallax is caused or seen due to which condition? It is seen when we use double emulsion film. Okay. So this is based on principle of projection geometry. Okay. So I hope this concept is clear and this is the concept that you need to understand. Okay. Chalo. Moving on to the next question. The CT images shown below depict a condition due to elongated bone. Okay. What is the condition it will cause? We have four neuralgia given in the options. First of all, you need to identify which bone is that. Which bone is elongated? This is coronal slice, this is sagittal slice of CT, and this is the 3D image. Okay. So, which bone is this? The elongation of which bone is seen over here. This is a bone which is elongated. Okay. This is nothing but a styloid process. Styloid process. So elongation of styloid process. When you uh, recall in which condition you see elongated styloid process, in which syndrome you see elongated styloid process, when you recall this, you will get to the one syndrome, that is Eagle syndrome. Eagle syndrome, correct? In Eagle syndrome, you see elongated styloid process. Now, what happens when this elongation occurs? What happens? So, this elongated styloid process What it will cause? It will cause compression of nerve. Compression of nerve. Which nerve? Ninth nerve. Ninth nerve is which nerve? Glossopharyngeal nerve. Glossopharyngeal nerve. Correct? When there is a elongation, there is a compression of ninth nerve, which is glossopharyngeal nerve, and this compression leads to throat pain, ear pain, dysphagia, okay, and then pain radiates to tonsillar region, jaws, and tongue. So this posterior region, pharyngeal, tonsillar, everything, this pain radiates to all of these regions, and the pain becomes worse on swallowing, yawning, and when patient rotates his head to side, okay, side to side, then this pain becomes worse. Rotation of head to side. Okay. Now, this all activities leads to worsening of pain, and this compression of glossopharyngeal nerve will mimic which neuralgia? Glossopharyngeal neuralgia. Correct? This pain, whatever pain occurs in this condition, mimic the pain that is there in glossopharyngeal neuralgia. So, our answer for this question is option number A. Option number A, glossopharyngeal neuralgia. Again, I'll tell you, when there is no option such as glossopharyngeal neuralgia, then you can go for alternative option as option number 2, which is otic neuralgia. Why otic neuralgia? Because patient will have a deep ear pain also. And ear pain is due to referred pain. Okay. When there is a compression on glossopharyngeal nerve, the pain refers to ear. Okay. And that can mimic otic neuralgia. So when there is no glossopharyngeal neuralgia in your option, you can go for alternatives as option number B. Okay. I hope this is clear. Question number 4. Now, moving on to fifth question. 10 years old boy, 10 years old boy comes for multiple caries teeth. Okay. And there is an image of OPG given. And the history, they have given a medical history that he's been treated for Hodgkin's lymphoma at 2 years of age. When he was 2 years of age, he's been treated for Hodgkin's lymphoma with radiotherapy as well as chemotherapy. Okay. What is the effect seen on the roots of permanent teeth? Roots of permanent teeth. Okay. Now, can you see in the OPG, can you see the roots, the root formation is not complete. Correct? The growth of the teeth is not complete. There is a malformed root formation that is seen. Okay. Now, this relates to, I'll just tell you, this question they have just picked up from the caption. Okay. This is given in white and farrow, this exact image. And whatever given in the caption, they have just picked up this caption and given you that question. Okay. So, what is the conclusion here? Please just go through the caption once when you are reading your textbooks and referring textbooks. Just please have a look at the captions also. Sometimes they pick the direct question from there. Okay. So, this condition, the retarded root development, they are just asking what is this condition called as. Okay. So, I'll just give you the details when the children receiving radiotherapy, correct? Uh, the children, the permanent teeth are in eruptive stages, correct? Permanent teeth are in eruptive stages. So, when children undergo radiotherapy, there will be defects, sorry, there will be defects seen in the permanent teeth. Okay, now what defects do you see? You will be seeing retarded root development. You will be seeing dwarf teeth or just a failure to form one or more teeth. Okay, now this also depends when the exposure, if radiotherapy, when the children or child receives radiotherapy before calcification, before calcification, okay, before calcification of tooth, then it may destroy the tooth bird. It may destroy the tooth bird. Okay, if radiotherapy is given after calcification, these are very important points. Please write it down or you can just remember. If radiotherapy is given after calcification of teeth, then it may inhibit cellular differentiation. Cellular differentiation. Okay. This can cause malformation, malformed teeth, or, or it arrests the growth, general growth of the teeth. Arrest growth means it retards root development, root formation. Okay. And the word that they have given for this is stunting. The word that they have used for retardation of root development is stunting. So please remember the word stunting. Okay. So these are the effects when a child is given a radiotherapy. Okay. That too, if that depends on if it is given before calcification or after calcification. These are the changes or the effects that you get to see. Okay. Next important point is just a second. I think there is some technical. Okay. Okay. Next important point is very important point. The eruptive mechanism. Eruptive mechanism is resistant to radiotherapy. Meaning what? Eruptive mechanism is resistant to radiotherapy. Even if the growth is retarded, there is a malformation in the root, the tooth will erupt into oral cavity. Okay, the eruption is not affected by radiation. So eruptive mechanism is resistant. Okay, so here in this OPG, if you can see in this radiograph also, there is retarded root development, still the tooth has erupted into the oral cavity. Okay, here also in OPG you can see there are malformed root formation, but teeth are erupted into the oral cavity. Okay, so this is also one of the important point that they can, based on this, they can ask you questions. All right, moving on to the next question. Salmon patch is a form of, so last year PYQ, and this was not expected, this word. Okay, uh, so I'll just tell you salmon patch. Salmon patch is a word for Nevus simplex. This is the word that we have it in the textbook. Nevus simplex. Okay. Now, what is this nevus simplex salmon patch? Okay. We'll be talking about that. Okay. You must have heard of vascular anomalies. In this also, I am going to tell you most important points. So please uh, write it down or remember. Okay. All right. So, what are vascular anomalies? They are abnormalities of vessel structure. They are abnormalities of vessel structure. Correct? Now, vessel. Vessel can be artery. So, they can be arterial malformation. They can be venous malformation. And they can be capillary malformation. Correct? The most important is how the arterial malformation, what is the feature seen in arterial malformation. So arterial malformations are pulsatile, these are important words, warm and firm. Arterial vascular malformation are pulsatile, warm and firm. Venous malformations are soft and compressible. Soft and compressible. All right. Now coming on to capillary malformation. अभी capillary malformation में we have two types of capillary malformation. Capillary malformations. Okay. First is nevus simplex. Nevus simplex, which is also called as salmon patch. Okay. Second one is the nevus flammeus. Nevus flammeus is also called as port wine stain. This we have heard, right? Port wine stain. Now, nevus simplex is very common, and 40% newborns will have this salmon patch. 40% newborn. Okay, they appear as flat pink patches. Flat pink patches. And the location is either on the forehead or nape of the neck. When it is on the forehead, it is called as angel's kiss. When it is on the nape of the neck, it is called as stroke bite. Okay. So nevus simplex is or appears like this, is on the forehead. 40% newborn will have this, and nevus simplex is the only vascular malformation which involutes means regress. Okay, nevus simplex is the only vascular malformation which involutes or regress. Okay, so this is angel's kiss. It's on the forehead. When it is on the nape of the neck, it is called as stroke bite. Okay, the second one is port wine stain. Can you see this? This is nevus flammeus. Port wine stain. Can you see the color? Color can be purple or dark red. Dark red. Okay, face is most commonly affected then compared to any other body part. Okay, and it appears on one side of the face and clear midline cutoff. Can you see clear midline cutoff? This is the feature of nevus flammeus or port wine stain. And we know port wine stain, we see it in which syndrome? We see it in Sturge-Weber syndrome. Correct? Sturge-Weber syndrome. So, coming on to our question, salmon patch is form of vascular malformation. Okay, so I hope this is clear. I hope this is clear. All right. Chalo, moving on to question number 7. This is most commonly asked. Paranasal sinuses are best viewed by. There are some views given, and they have asked about paranasal sinuses. PNS, paranasal sinuses are best viewed by. Hmm. We will go from option number A, reverse towns. Reverse towns is used for, we all know, fracture of high condylar neck. Fracture of high condylar neck. Correct? I know many of you will answer this question as option number B. Option number B. But because of that only I have put this question as very important, because paranasal sinuses includes all the four sinuses. Okay? And the Waters view is specifically for viewing maxillary sinus. Waters view is specifically to view maxillary sinus. So that's why I put this question, because many of you get confused. And paranasal sinuses, when we talk about paranasal sinuses, we have PA view to PA view. PA view is also called as occipitofrontal view. Occipitofrontal view. Okay. And Granger view is nothing but our PA view. Granger view is nothing but PA view. And we have modified PA view also. Modified PA view. Modified PA view is called as Caldwell view. Caldwell view. And this PA view is used to view paranasal sinuses. And we will mark the best possible answer. The modified technique for it, it's Caldwell view. Okay. So option number D is our answer, correct answer. And this Caldwell view will appear somewhat like this. Somewhat like this. Caldwell view. Okay, where you can see maxillary sinus, where you can see ethmoidal sinus, where you can see frontal sinus and the part of sphenoid sinus. Okay, so you can see all the four sinuses in this view. All right. So Caldwell view used for viewing paranasal sinuses. And if the question is modified as maxillary sinus is best viewed using, then your answer will be Waters view. Then your answer will be Waters view. Okay. I hope this is clear. Chalo. Moving on to, yeah, I'll just show you other views also, so that uh, sometimes they just give you this they just give you this view, uh, skull views, and they ask which structure is best viewed using this. Okay, so this is nothing but reverse towns. Reverse towns. Now reverse towns mein, can you see the condyle very clearly? This is a condyle, and you can see the high condylar neck fracture. High condylar neck fracture means here if there is a fracture, here if there is a fracture, then you can easily view it using reverse towns. All right, moving on to next. This is nothing but Waters view. Waters view. Okay, Waters view mein, can you see maxillary sinuses very clearly? This is a maxillary sinus and specifically used for viewing maxillary sinus. This is Waters view. Okay, so please remember how these views appear and what are they used for. Okay. Chal, moving on to the next. Okay. So chances of oral carcinogenesis is highest with. This is also easy question, but what I would tell you ki what options they have given na, they ask frequently uh, questions based on these all syndromes. These all syndromes are very important. So I am going to describe each syndrome, and then at the end we will conclude in which syndrome you see oral chances of oral carcinogenesis. Oral carcinogenesis is our um, important term. Okay, first, first is Peutz Jeghers. Okay, Peutz Jeghers में I am going to tell you mutation in which gene also and what features do you see in these syndromes. So mutation in STK11 gene, STK11 gene. Okay, what you see in Peutz Jeghers is multiple hematomous polyps in GI tract. In GI tract. Okay, and there will be Peutz Jeghers means perioral pigmentation is also there. Perioral pigmentation is also there. Okay, so chances of GI cancer, there are chances of GI tract cancer is there. This perioral pigmentation which is seen in Peutz Jeghers is not at all malignant. Okay, it is not pre-malignant at all. The polyps which are there affecting GI tract can be cancerous. Okay, this is Peutz Jeghers. Second one is Gorlin Golds. Gorlin Golds syndrome, we call it as nevoid basal cell carcinoma syndrome. Correct? Now, in Gorlin Golds, what mutation in which gene? PTCH. Mutation in PTCH gene you see, correct? And what features you see other than Gorlin Golds ka oral feature? What feature you see? Multiple OKCs, correct? Multiple OKCs. But these OKC are recurrent but still benign. These are benign, not malignant, correct? So chances of oral carcinogenesis again low. Apart from multiple OKCs, you see BCC, basal cell carcinoma of skin, skeletal abnormalities like bifid ribs, Fox cerebri calcification. Okay, so no direct link to oral cancer or oral carcinogenesis. Oral carcinogenesis. Okay, I'm emphasizing on oral cancer, not any other cancer. Moving on to the next syndrome, which is Gardner syndrome. Now, Gardner syndrome mein we have multiple colorectal polyps, correct? And there are 100, there is 100% chance that they will be undergoing malignant transformation. 100% chance in Gardner syndrome. Whatever multiple colorectal polyps are there, 100% chance that they are going to convert into malignancy. Okay. Extra intestinal features that we have in Gardner's is multiple osteomas. Osteomas of jaw, multiple supernumerary teeth, epidermoid cysts, and fibromas. And fibromas. Okay. So these are extra intestinal features that you see in Gardner syndrome. And there is no direct link to oral carcinoma as such in Gardner's. Okay. No direct link to oral carcinoma. Now, the last option that we have is xeroderma pigmentosum. Now, name itself suggests zero. Zero means what? Dry. Derma is skin. Dryness of skin. Pigmentosum means hyperpigmentation. So, hyperpigmentation, we'll name it as a freckling. Okay. So this condition is autosomal recessive condition. Autosomal recessive condition. Okay, what exactly happens here is there is a defect in nucleotide excision repair, NER, in UV damaged DNA. UV damaged DNA. Nucleotide excision repair. Okay. So when there are sun exposed areas, okay, so in oral cavity, what are most common sun exposed areas? We have lips, we have tip of the tongue. There are high chances that this condition can cause SCC, squamous cell carcinoma of lip, of tip of the tongue. Okay, because they are sun exposed areas. Okay, and apart from this lips and tip of the tongue, the skin cancers, you have BCC, SCC seen in this condition. Okay, so skin cancers, oral cancer. So the final answer to this question, okay, chances of oral carcinogen is highest with xeroderma pigmentosum. Okay, so UV, sun exposed areas, whatever are there, are more prone to SCC, squamous cell carcinoma, in this xeroderma pigmentosum. All right, I hope this is clear. Okay, moving on to the next question. This is also most commonly asked. Image shown below represents. So they will give you this skull view, okay, and the radiographic appearance seen in the skull view. There are 5 to 6 skull appearances that you should be thorough with, okay, and this here you see there are well defined, punched out. The word is punched out radiolucency. Punched out, well defined, punched out radiolucencies in the skull region. Okay, and this you see it in which condition? You see it in multiple myeloma. You see it in multiple myeloma. Correct. Okay, so when we look at the other options, okay, look at the other options. You can rule out other options too. When you don't know the answer, please rule out other option and then mark the correct one. Okay. But for that, you need to know the features of other options also. Correct. So in Paget's disease, what is the radiographic appearance that we see? Paget's disease mein we see cotton wool appearance. So in mandible, you see this multiple radio opacities giving cotton wool appearance. Okay. So Paget's disease also ruled out. Second one, mandibular facial dysostosis. This is Treacher-Collins syndrome. Treacher-Collins syndrome mein, uh, the important feature is bird facies. Okay, bird-like face, and the radiographic feature, you see hypoplasia of ramus and condyle. Hypoplasia of ramus and condyle. Okay, not that prominent radiographic feature seen in Treacher Collins. Okay, so last option that we are going to rule out is cleidocranial dysplasia. Cleidocranial dysplasia may be what you see. The radiographic appearance can be multiple unerupted supernumerary teeth. Supernumerary teeth. This can be one of the radiographic feature. Okay, and the systemic, the skeletal abnormality is what? Hypoplasia or absence of clavicle. Correct? Absence of clavicle in cleidocranial dysplasia. So when you have other options, please go through other options also and just recall what other characteristic feature, what important characteristic features are seen in other syndromes. All right. So question 9 ka answer is option C. Easy. Punched out radiolucencies. Even if they don't give you the skull, they'll give you the OPG and the mandible, and in the mandible you have this punched out radiolucencies, well defined punched out. Then you mark the answer as multiple myeloma. Okay. Chalo, moving on to the last question of the day, which is, which of these potentially malignant lesion has the highest chance of malignant transformation? Highest chance of malignant transformation. This question we have discussed is multiple times, correct? Okay. So, hmm, I repeatedly give you this sequence of malignant potential: PVL, then comes our erythroplakia. Okay. Now I will give you the comparison among these options only. Okay. Then we have OSMF, and then we have lichen planus. Among given options, PVL has got highest uh, potential of malignant transformation. Okay. But if we compare leukoplakia, PVL, then erythroplakia, then we have heterogeneous leukoplakia, then we have homogeneous leukoplakia. Okay. So please remember the sequence and the malignant potential of each lesion. All right. So this completes our 10 questions. Most important PYQ. Please go through it once again and just feed it into your brain. All right. And if you have any doubts, you can ask me or you can post it in the Telegram group always. So I, if you have any doubt, you can ask. Otherwise, we can conclude the session. All right. I guess there are no doubts. So we can conclude the session. All the best to everybody and good night.